Thank you for joining me as we delve deeper into the topic of COVID-19 vaccination and the pressing issue of vaccine inequity in Africa. My name is Adidja Amani. I'm a physician and a vaccinologist. And today, we will explore what progress has been made in addressing vaccine equity issues in Africa, how we can improve communication with the public about COVID-19 vaccine, and the consequences of not achieving vaccines equity. First, let's look at the current situation regarding COVID-19 vaccination rates. COVID-19 vaccination vary widely across Africa, painting a picture of stark disparities. In countries like Madagascar, only 9% of the population has received at least one dose of the COVID-19 vaccine, while in South Sudan, it stands at 39%, and in Rwanda, a more promising 79% is achieved. This variation highlights the urgent need to address vaccine equity. Vaccine equity is about ensuring that all people, regardless of their location, have equal access to vaccines that protect against COVID-19. Currently, 73% of the population in high-income countries have been vaccinated, meaning that 3 in 4 people are protected. In stark contrast, only 35% of the population in low-income countries has received the vaccine, equating to just 1 in 3 people being vaccinated. The cost of vaccinating 40% of the population relative to the current health expenditure reveal a significant burden. High-income countries, on average, need to increase healthcare spending by 0.8% to cover the cost of vaccinating 40% of their population. While this represents a manageable burden, it still emphasizes the importance of allocating resources to ensure equitable vaccine distribution. For instance, the United States requires a mere 0.1% increase in healthcare spending, and the United Kingdom stands at 0.3%. Unfortunately, the story takes a different turn when we look at low-income countries. These nations face a staggering financial burden. Numerous barriers contribute to vaccine inequity in Africa. These include intellectual property and profit, lack of technology transfer, low funding, supply and access, vaccine hoarding, vaccine misconception, and weak healthcare systems. The influence of healthcare workers cannot be underestimated. Healthcare workers, especially those embedded within communities, remain the most trusted advisor and influencers of vaccine decisions. People are more willing to get vaccinated if they receive recommendations from their healthcare providers, friends, family, acquaintances, faith leaders, even or state officials. Healthcare workers play a pivotal role in influencing vaccination decisions. This encompasses communicating the benefits and potential adverse events of vaccine, administering and scheduling doses, managing and reporting side effects, observation of precaution and contraindication, vaccination storage, and handling of vaccines. However, it is crucial to acknowledge that healthcare workers in Africa have faced numerous challenges during the COVID-19 response. The challenges include a lack of resources and equipment, like we've seen in Ethiopia, for instance. It was reported that up to 50% of the health workers were not at all satisfied with the medical equipment that were available for COVID-19 treatment. In countries like Kenya, we also observed limited intensive care units and bed surge capacity shortages, breathing intervention, and shortage of ventilator in intensive care units. In addition to the resources deficit, there is also a deficit in training opportunities for healthcare workers. A survey conducted in 2021 among thousands of healthcare workers revealed that only 37% received training COVID-19 management and treatment. Shockingly, less than 30% were trained on how vaccines work, and only 23% were trained on managing vaccination program. Vaccine hesitancy poses a substantial challenge for healthcare workers during the COVID-19 response. Studies have indicated that acceptance rates vary widely across Africa, ranging from 7% in countries like Nigeria up to 98% in Ethiopia. The COVID-19 response has also taken a toll on the mental health of healthcare workers in Africa. Studies have shown that a significant percentage of health workers reported psychological distress, anxiety, up to 8% of them. Vaccine acceptance rates among healthcare workers vary globally and significantly. While countries like Canada or Greece have an acceptance rate of up to 80%, we observe that in Africa, the acceptance rate is only at 58%. Quite interesting, which is also the case in the United States of America. Several factors have contributed to this. This includes witnessing patients experiencing side effects, concern over safety and effectiveness, the perceived speed of vaccine development, the lack of belief in vaccine benefits, confidence in one's immune system, distrust in information sources like information coming from the government, and sometimes the lack of information at all. The global vaccine inequity has had profound consequences on the COVID-19 pandemic. It has prolonged the crisis, increased poverty rates, led to more debt, damaged economies, and heightened the risk of new variants. Several strategies have been implemented to address the vaccine inequity in Africa. Initiatives like the COVAX, which is a part of the Access to COVID-19 Tool Accelerator, have shipped over 700 million vaccines doses to Africa. COVAX has delivered to 50 countries, African countries, and 63% of the doses doses of vaccine in Africa has arrived through COVAX. And among those, 69% of the received doses has been administered. To further tackle the vaccine inequity, the European Union has undertaken a remarkable humanitarian initiative to support COVID-19 vaccination rollout. with up to 100 million in humanitarian support, the sharing of 145 million doses of COVID-19 vaccines, and a targeted focus in fragile and conflict-affected settings, and we know this is where really inequities lie. The European Union has significantly improved vaccination rates in vulnerable African countries. And with this, we observe that by early 2022, vaccination rate was less than 5% on the continent, and it has reached approximately 30% in the continent after their support. One particular impactful initiative is the mRNA vaccine technology transfer hub. This global effort aims to scale up messenger RNA vaccine manufacturing in low and middle income countries by providing essential technology development, training, and technology transfer. Low and middle income countries really can develop their own vaccines and therapeutics, not just for COVID-19, but also for other diseases that threaten this country. Now, let us delve into the topic of improving communication with the public in Africa about COVID-19 vaccines. The COVID-19 vaccination campaign in Africa has involved a range of vaccines to meet the diverse needs of different populations. In total, 1,084 million doses has been administered. Among these, the Janssen vaccine accounts for 36%, the Pfizer-BioNTech for 22%, AstraZeneca 15%, Sinopharm 13%, Sinovac 6.8%, Moderna 4.6%, and Sputnik 0.4%. To build trust and effectively communicate about vaccine, it is crucial to have real-world data on vaccine efficacy and safety in African population. For instance, a study conducted in Nigeria and Ghana among 667 participants examined the effectiveness of the AstraZeneca vaccine in generating neutralizing antibody against SARS-CoV-2. The finding shows that individuals with previous exposure to the virus had stronger immune response after vaccination. Similarly, in South Africa, real-world data have assessed the effectiveness of the Pfizer vaccine against the Omicron variant. The vaccine effectiveness during the Omicron period was 70%, which was maybe a little bit lower than the 93% effectiveness seen before the Omicron emerged. But while the effectiveness was lower during the proxy Omicron period compared to the comparator, the Pfizer-BioNTech vaccine still offer a substantial protection against hospitalization and intensive care unit admission. The effectiveness of the Johnson & Johnson vaccine, as well as the effectiveness of the Pfizer-BioNTech vaccines, were quite high, not only against severe cases requiring ICU admission, but also high against hospitalization, with numbers ranges up to 71% for the Pfizer and 74% for the Johnson & Johnson. Moving on, a study conducted in Zambia revealed that COVID-19 vaccination significantly reduced in-hospital mortality. Individuals who received at least one dose of vaccine had a lower mortality rate compared to the unvaccinated group. So these findings emphasized the importance of vaccination in reducing severe outcomes and highlights also the critical role in fighting the COVID-19. Let's shift now our focus on vaccine safety. Real-world data from Sudan demonstrate that the over 35% experience common side effects. The most frequently reported included pain at injection site, fatigue, headache, or fever. Moving on to the next study on vaccine-induced vascular thrombotic events, real-world data from South Africa indicate that the risk is low. So this was a study conducted among healthcare workers who received the Johnson & Johnson vaccine, which showed that overall there's a low incidence of specific thrombotic events. Now that we understand the efficacy and the safety of COVID-19 vaccine in African population, let's explore the intervention proven to increase vaccine uptake. Several strategies have been successful in this regard, including formative research, risk communication and community engagement, internal partner coordination among institutional or organization, provision of public health education on vaccine and possible risk, and also really addressing vaccine-related rumors and misconceptions. Now let's examine 3 case studies that demonstrate the effectiveness of people-centered approach. Community mobilization efforts were successful in expanding COVID-19 vaccination. So Sierra Leone based this approach drawing from the experience they had during Ebola outbreak. Over 1,800 community mobilizers were deployed across 13 districts to address rumor, engage with communities, and develop customized vaccination plans consisting of gain trust and respect, address language and cultural barriers, public vaccination of traditional leaders, engage local healthcare workers and community leaders, but also engage communities in action planning, designing, and implementing tailored vaccination plan, and finally dispel rumor around vaccination. Similarly, the Lesotho Red Cross Society targeted special populations such as construction workers, old-age pensioners, traditional initiates, or herd boys. So the community-led action initiative fostered dialogue and action planning with communities through a combination of one-on-one interaction, group session, and public addresses dedicated volunteers, which successfully led to reach more than 1,000 individuals in the district in February. Quite a successful strategy. In Kenya, mobile clinics were launched to address slow access to and uptake of COVID-19 vaccines. The clinics aim to serve communities with limited or no access to vaccine and other health services. So initially designed to vaccinate 70 to 100 people per day, really the goal is to reach 1,000 people per day once all the 11 mobile clinics are fully operational. The mobile clinics are an innovative solution to strengthen primary health care and provide essential services to underserved communities, supporting, of course, universal health coverage. Now, let's discuss best practices for healthcare workers' communication on COVID-19 vaccines and the crucial role they play in promoting vaccine uptake. The strategies implemented in Nigeria and in South Africa to empower healthcare workers in promoting COVID-19 vaccination can be summarized as follows. First of all, there was a training that was provided. Healthcare workers were trained through in-person sessions, but also through virtual coaching. Secondly, they were equipped with digital and print material. And thirdly, they were to wear lapel pins to signify that they have been vaccinated, fostering then a social norm and encouraging others to follow suit. To further support healthcare workers in their communication efforts, best practice guidance has been developed by UNICEF. So they have created a guide specifically designed to assist the healthcare workers in a 4-step: listen, ask, educate, and return. Firstly, healthcare workers should actively listen and answer questions without judgment, establishing a relaxed body language and eye contact. Secondly, healthcare workers are encouraged to ask questions to better understand, concern, and correct any misinformation. Then, healthcare workers are also encouraged to educate, and we all know the power of storytelling. So, this storytelling should focus on highlighting the benefits of vaccines. It is essential to avoid overwhelming individuals with complex terminology or jargon. If you don't have the answer, it's okay to say you don't have the answer. It's important to learn how to prepare conversation with vaccine-hesitant individuals. Healthcare workers can access practical guides provided by organizations like Breakthrough Action and UNICEF. These guides offer reference material to help them navigate different patient scenarios, including addressing safety concerns and regarding the COVID-19 vaccines. The guides provide examples of what healthcare workers can say to effectively address this concern and build trust with their patients. And in this example by Breakthrough Action Nigeria, they've developed online learning videos specifically tailored for healthcare workers. This video serves as job aids and can be utilized while engaging with clients. By utilizing these online materials, healthcare workers can enhance their knowledge, they can build trust, and also effectively communicate the importance of vaccine to their patients. And finally, let's look at the digital health technologies. They are widely used in sub-Saharan Africa to increase vaccination rate and support healthcare system. These technologies ranges from electronic health record, telehealth, assisted living, mHealth, e-prescribing or e-appointment, and data-driven automation. These technologies serve various purposes, including delivering healthcare remotely, mapping health services and population level needs, manage drugs and supply, and facilitate digital system for integration and central reporting. Additionally, digital technology supports tools like Safe Care for COVID, which provide practical support during the COVID-19 crisis. The Safe Care for COVID is a free app which provides practical support and offer guidance to treat patients for COVID while ensuring the safety of healthcare workers. By utilizing digital tools, healthcare workers can ensure the availability of equipment, review processes, and access up-to-date information to deliver high quality care while staying safe. And on this slide and on this note, I would like to thank you for your kind attention and look forward to see you on the third part of the presentation. In this final part of our presentation, I will shed light on the dire consequences that persist if we fail to address this inequity and take decisive action. Vaccine inequity has far-reaching consequences for the socio-economic landscape. The economic impact is profound, with a drop in GDP, the gross domestic product, worsening trade balance, jobs and livelihood losses, wealth depletion, and increased health spending. These effects have caused the collapse of domestic supply chains, stalled economic activity, and heightened financial distress. On the social front, the loss of lives reduced social spending, disruption of social services, and growing inequalities, which are leading to widespread deprivation, social disaffection, increased inequalities, human development losses, and even social unrest. Healthcare system in Africa are significantly impacted by vaccine inequity. The lack of equitable vaccine distribution has led to various challenges across the continent. These challenges include the emergences of the long COVID, which poses a substantial burden on individual and healthcare system. Additionally, patients requiring chronic care services often miss scheduled appointments, disrupting their health outcome and straining healthcare resources. The reorientation of services towards COVID-19 response has deterred the provision of essential healthcare services, leading to a decline in population health. Furthermore, underlying health conditions like HIV, tuberculosis, along with limited vaccine access, make parts of Africa particularly vulnerable to contagion. Women face even greater barrier to accessing critical health services, exacerbating gender disparities. The reduced patient flow and limited access to healthcare exacerbate the strain on healthcare facilities and compromise the overall quality of care. It is imperative that we address vaccine inequity to protect the health and well-being of Africans. The pandemic has taken a toll on people's mental well-being. In Africa, where pool prevalence rate of anxiety was up to 47% and depression 48% reported, the toll on mental well-being is particularly pronounced. Factors such as lockdown measures, increased morbidity and mortality, economic decline, job losses, and travel restriction have exacerbated the mental health challenges, as we see with these really staggering figures. Vaccine inequity during the COVID-19 pandemic has had severe consequences for economies and employment worldwide. In countries like Cabo Verde, we've noticed a suspension of flights, which resulted in a staggering 20,000 job losses, contributing to a significant 6.3% loss in gross domestic product. In Kenya, restriction on flights, curfews, and public gathering led to job and income losses, as well as delay at borders, causing businesses to suffer. Nigeria faced travel ban, school closure, and regional lockdown, leading to unemployment and disruption in vital sectors such as food production agriculture, mining, trade, transportation, or even leisure. The emergence of new variants of COVID-19 virus presents also a substantial risk. While vaccine and control measures have provided hope, the evolving nature of the virus and its variant raise concerns about the impact of vaccine effectiveness and the potential for increased transmissibility, immune escape mutants, higher infection rates, and the erosion of prior immunity are among the challenges posed by these variants. Reintroduction of preventive measures, increased hospitalization and death, further emphasize the need for vigilance and adaptation. It is crucial that we embrace ongoing surveillance, research, and development to stay ahead of the virus. Variants of interest continue to emerge, highlighting the ever-evolving nature of the virus. New COVID-19 variants of interest are continuously emerging, and the World Health Organization is closely monitoring two specific variants as of June 29, 2023. The first variant is the XBB 1.5 that was initially detected in the US, and it raised concern due to its potential for increased transmissibility and impact on immunity. The second variant, which is the XBB 1.16, it was predominantly found in India and is worrisome because it has a growth advantage and characteristic that may enable it to evade immune response. So monitoring these variants is crucial for understanding their behavior and informing public health strategies. Recommendation by the World Health Organization's Strategic Advisory Group of Experts, the SAGE, provide crucial guidance on COVID-19 booster vaccines. In fact, the SAGE met last time in March 2023 and provided recommendations based on the changing COVID-19 landscape, including the dominant Omicron variant and increased population-level immunity. The roadmap suggests longer interval for booster dose in high-priority use group, no routine boosters for medium-risk group, and additional boosters for pregnant and frontline healthcare workers, and consideration for primary vaccination for children and adolescents based on country-specific factors. These recommendations aim to adapt vaccination strategies to the evolving situation and individual risk profiles. The importance of booster doses cannot be overstated. Boosters have been found to reduce severe illnesses and mortality, and 35 countries in Africa are really starting to offering booster doses. We know that boosters enhance vaccine effectiveness against infection, symptoms, and severe outcome, whether given with the same vaccine or a different one. So by prioritizing booster dose and ensuring their equitable distribution, we can safeguard the gains made in the fight against COVID-19. So this leads us to the summary of our presentation. In part one, we delve into the progress made and the challenge faced in addressing vaccine equity in Africa. We explore the disparities in vaccination rates, but also we look at the importance of healthcare workers as trusted influencers and the challenges they face in the fight against COVID-19. In the second part of the presentation, we reflected on the progress made, and it becomes evident that improving communication with the public in Africa about COVID-19 vaccines is crucial for widespread vaccine uptake. Despite the challenges on the mental health, on the socio-economic life, we have a window of opportunity that presents to us, like the mRNA technology transfer program, which focus on locally owned manufacturing capabilities, and it holds the potential to transform vaccine production in LMIC. Now, on this, I will invite you to join Professor Melhem, who will guide us through the next phase of our journey as we explore COVID-19 vaccine inequity in the Middle East and the potential solution to address this pressing issue. Thank you.
Hello, everyone, and welcome. My name is Nada Melhem. Today, I'll be answering the following questions. What progress has been made in addressing COVID-19 vaccine equity issues in the Middle East? How can communication with the public in the Middle East about COVID-19 vaccine be improved? And finally, what would be the consequences if vaccine equity is not improved in the Middle East? This part of this video will address the progress that has been made in addressing COVID-19 vaccine equity issues in the Middle East. There is a wide variation in vaccination rates across countries of the Middle East. And when we assess the proportion of population who have received at least one dose of COVID-19 vaccine, it is clear that countries like Syria, Iraq, and Lebanon are still at less than 50% vaccination uptake compared to a range of 68 to 100% in low middle income countries as well as higher income countries. Vaccine equity means that vaccines should be allocated based on needs. This is based on the principle that vaccination is a human right in order to attain a healthy life. Unfortunately, global COVID-19 vaccination rates have been correlated with income status, with vaccination rates in low-income countries reaching only 26%, 59% in lower middle-income countries, whereas upper middle-income countries are at more than 74%. Keeping in mind that the income in countries of the Middle East varies widely, this disparity may contribute to vaccine inequity accordingly in the region. Despite the effectiveness of COVID-19 vaccination rates appears to be slowing across time and have plateaued across countries of the Middle East. And again, we still have a number of countries that are still at suboptimal levels of vaccination uptake. A number of barriers have been advanced to vaccination efforts in the Middle East. Fear of side effects, the lack of trust in vaccine safety or efficacy, attitudes towards pharmaceutical companies, as well as misinformation about COVID-19, the disease itself, and COVID-19 vaccines. In addition to public perception, unreliable supply of vaccines, as well as unequal vaccine distribution, exert important barriers to vaccination efforts. Importantly, women in the Middle East have been shown to face additional barriers, whereby they are less autonomous and they have the greater burden of caregiving at home, and thus preventing them from accessing COVID-19 vaccines. Lower socioeconomic status or minority status is also associated with poorer vaccination rates. Healthcare workers are central in the fight against COVID-19, as well as other types of communicable diseases. Healthcare workers are trusted figures of the community, and they are considered reliable sources of information, and thus role models for vaccination. Their recommendation can increase vaccine uptake. Their refusal or hesitancy can negatively impact perception. And this is why it is important for healthcare workers to be vaccinated in order to reassure the public. A large multinational studies conducted in the Middle East determined healthcare workers' vaccine acceptance rates. And unfortunately, this ranged between as low as 8.6% to a maximum of 49% in Kuwait. When Arab-speaking healthcare workers participating in the study were asked about the reasons for vaccine hesitancy, they advanced the following reasons: fear of unknown side effects, insufficient safety testing, lack of trust in healthcare policies, the rushed vaccination production, and then no efficacy values or effectiveness studies against the new emerging strains. Keeping in mind that this study has taken place in January 2021, and those results might have changed with time. In order to promote equitable access to vaccination, COVAX, the vaccines pillar of the Access to COVID-19 Tools ACT accelerator, aims to accelerate the development and manufacture of COVID-19 vaccination in order to guarantee a fair and equitable access for every country. The total number of doses allocated to low-income countries, upper middle-income countries, lower to middle-income countries, compared to high-income countries, have been extremely larger. And despite this high allocation of this large number of doses, we still have suboptimal levels of COVID-19 vaccination in low-income countries as well as lower middle-income countries. Fortunately, a number of countries in the Middle East have been leading in COVID-19 vaccination. The United Arab Emirates, or the UAE, has successfully implemented their vaccination policy with high rates of public uptake. They were able to vaccinate the total population. They were able to administer booster shots to 54% of their population. They ranked second globally for daily vaccine distribution, whereby they were able to distribute 6 doses per 100 people. And the public showed high satisfaction with COVID-19 strategies. In order to lead in COVID-19 vaccination, they used various strategies to spread positive messages and to ensure ease of access to the vaccine. They engaged leaders in order to promote vaccination and to address misinformation. Ministers, for example, got vaccinated early on in order to set an example. The government has also partnered with pharmaceutical companies such as Sinopharm in order to run phase 3 vaccine trials and to share the data with the nation. They were able to continuously sending positive messaging to reassure the public. They worked with religious leaders to do so. They used social media platforms to share information in multiple languages. And they supported easy access through mobile apps for booking appointments, as well as drive-through and walk-in vaccination centers. Qatar is another country that led a successful campaign with rapid vaccine uptake and rollout. In fact, as of December 2020, and immediately following the release of the emergency use authorization of the messenger RNA-based vaccine, Pfizer-BioNTech, they started administering that vaccine to their population. And by May 2021, they had more than 50% of their population vaccinated. Between August 2021 and September 2021, they were able to start administering their booster shots. And by August 2022, more than 100% of the population was fully vaccinated. The Ministry of Health in Qatar used combined strategies to implement a broad spectrum of strategies across a diverse population. They supported access to COVID-19 vaccines by contacting the public by phone. They opened drive-through centers. They also used mobile apps to track transmission, to give updates about the disease. Social media campaigns were also conducted to answer questions from the public and to also target not only the nationals, but also the expatriates to increase awareness. In order to address hesitancy, they also ran TV and radio interviews in multiple languages, and they shared up-to-date information on government websites in order to keep the public updated. In summary, there remains wide variation in vaccination rates across countries of the Middle East. We have multiple barriers leading to this low vaccination rate that we must address. We believe that healthcare workers, a trusted source of information, play a key role in improving vaccine uptake. This concludes this section. Please join us for the next video. We will address in this section how can communication with the public in the Middle East about COVID-19 vaccines be improved. And in order to do so, we have to determine what are the misconceptions about the safety and efficacy of COVID-19 vaccines. A number of Middle East countries have conducted cross-sectional studies in order to identify those misconceptions. And the following was advanced. vaccination will not protect from getting sick with COVID-19. People may die as a result of negative side effect of the COVID-19. The COVID-19 vaccine is not safe. COVID-19 vaccines can cause autism, and COVID-19 vaccines may change our DNA. Fortunately, real-world studies, also from different countries of the Middle East, demonstrated the vaccine effectiveness in the region. In one of those studies conducted in the Kingdom of Saudi Arabia, whereby the aim of the study was to determine the effectiveness of the Pfizer-BioNTech vaccine, the AstraZeneca vaccine, as well as the Moderna vaccine, with or without booster shots, in 3,000 individuals, in order to determine their ability to reduce the risk of infection, as well as severe disease and consequently hospitalization. And in fact, all of these three vaccines showed more than 89% vaccine effectiveness in real world, as well as ability to reduce the risk of hospitalization. Another study was held in the United Arab Emirates, also to demonstrate vaccine efficacy in the Middle East. And in this study, the Sinopharm inactivated vaccine and the Pfizer-BioNTech messenger RNA-based vaccine were also compared in terms of reducing the incidence of confirmed cases among vaccinated, as well as the risk of hospitalization. And in fact, these results were again confirmed with specific results and data leading to reduced risk of hospitalization for Delta and Omicron variants. Another study from Bahrain determined the impact of using homologous versus heterologous prime boost regimen of vaccination, whereby in the homologous type of regimen, vaccinated individuals had two primary shots of the Sinopharm inactivated vaccine, followed by the same vaccine. And then the heterologous regimen included two shots in the primary series of Sinopharm, followed by the messenger RNA Pfizer-BioNTech vaccine. And in fact, both regimens were well tolerated and safe, and they both demonstrated robust immune responses. Qatar also conducted a large national study in order to determine the effectiveness also and generate real-world data following vaccination with Pfizer-BioNTech as well as the Moderna vaccine, both of which are messenger RNA-based vaccines. And both vaccines were able to protect against hospitalization and also against death. Pharmacovigilance data are extremely important in order to address the fear of side effects and this misperception. A study in Lebanon showed that general body aches, headaches, fatigue, and fever were common side effects that are experienced following the first dose of the Pfizer-BioNTech vaccine. Similar types of side effects were observed following the first dose of the AstraZeneca vaccine. In a recent UN report, special interventions were advanced and were proven to increase vaccine uptake in the Middle East and North African region. And these included peer vaccination, the use of social media in vaccine campaigns, addressing misinformation consistently, tailoring our communication about the risk to specific types of communities, to also work while respecting the social norms and the social customs in order to induce a positive behavior, and to continuously have community mobilizers and community engagement in order to increase vaccine uptake in the Middle East and North African region. The same report advanced that women in the Middle East have higher levels of vaccine hesitancy and accordingly lower vaccination rates. And a number of barriers were identified, and these included structural, social, as well as individual. However, the same report lined up specific interventions in order to address these barriers. For example, for limited mobility and time, we have to bring vaccines to places where women frequent mostly. For the cultural preference for female healthcare workers, for example, we have to promote and provide women-only vaccination sites and platforms. For fear of side effects, we have to share positive stories from trusted messengers and communicators. For lower perceived risk and need for vaccination, we have to continuously highlight the risk of getting COVID-19 and continuously use pro-social messaging in order to advance the benefits to the community. It is important as well to understand the behavioral as well as the social principles in order to send effective vaccine messaging. We should not always assume vaccine hesitancy. We have to build trust. We have to reinform, like we've mentioned before, social customs and social norms. We have to tell stories and happy stories and personal stories. We have to continuously remind people, why do we need to vaccinate? To protect against communicable diseases and COVID-19 as well. We have to anticipate cognitive shortcuts, and we have to continuously remind our audience that it is not good to do nothing about the risk of disease. We have to connect with people, values, and norms, communicate vaccination as an aspiration and a happy one and a happy event and a gain rather than an act. We have to be careful when we address the myths and misperception, because certain messaging can backfire. So we have to really craft it based on the type of the misinformation that we want to address. Importantly, we have to always recognize and acknowledge vaccine deniers. Similar studies were held as well in Lebanon, whereby at the American University of Beirut, we spearheaded a vaccination drive with the ambitious goal of vaccinating our entire community. And in fact, we were able to vaccinate more than 99% of the community by the end of this vaccination campaign. And we've done that through the use of websites to provide continuous information on where, when, how to receive the vaccine, the use of digital and social media as well, in English and in Arabic, through personal communication, through a very friendly booking system that was developed in order to promote access to vaccination sites, through email invites and updates, and also through using a catchy branding with a logo stating AUB vaccinated. Healthcare workers are central in the fight against COVID-19, and this is why messaging from healthcare workers should be clear and accurate. In addition, it should be evidence-based, context-specific, as well as culturally appropriate. We have to continuously know our target audience and understand their particular social and psychological factors in order to determine the way we address our messages in order to affect and impact decision to uptake the vaccine. Saying that vaccine is important is not enough, but we have to understand the needs and the motivations as well as the concerns of the communities and address those rather than only saying that we have to get vaccinated. Building trust is extremely important, and using messages such as "I vaccinated my children and you should too," or "I vaccinated my loved ones and you should too," can be an effective message. Healthcare workers should counter misinformation in order to build demand for vaccination. Misinformation, by definition, is a false information that is shared by people, including vaccine advocates, who do not realize that it is false and they do not mean any harm by it. And so this is why when we address misinformation, we have to lead by the truth. We have to explicitly explain the warning about the misinformation and repeat the misinformation only once. We have to also explain why the misinformation is wrong and address the fallacy of the misinformation. We should always and continuously not only lead, but also end by the truth, and in order to make it stickier than the misinformation itself, and accordingly fill the mental gap generated by the correction of the misinformation. Healthcare workers can engage as well with community leaders, specifically the religious leaders, in order to improve vaccine uptake. And the religious leaders are highly trusted by local communities and can often reach marginalized individuals and populations, and their support is extremely important and can complement and reinforce the work of national and global public health organizations. And they can do so by actually sharing the evidence-based information with their communities, by promoting avoiding large group gatherings and conducting faith-related activities virtually, by strengthening the mental health and the well-being and resilience through individual contacts, by ensuring a human rights-based approach to advocacy and to sharing the messages and delivery of these messages with the respective communities, addressing stigma as well as violence that could arise, and the incitement of hate is extremely important and can be readily reached to marginalized population through religious leaders. And importantly, religious leaders can support healthcare workers at ensuring that accurate information is shared with their respective communities in order to counteract misinformation. Vaccine efficacy and side effect profiles have been demonstrated from real-world studies and data from the Middle East. And effective communication between healthcare workers and the public has proven to be needed to improve vaccine uptake and to address misinformation. This concludes this section. Please join us for the next video. In this section, we will discuss what would be the consequences if vaccine equity is not improved in the Middle East. It is important to remember that vaccine inequity leads to global challenges. And these include the ability of the virus, specifically in this case SARS-CoV-2, the causative agent of COVID-19, to continuously mutate. And as a result of its mutation, new variants would emerge. These new variants might lead to peaks, larger ones, and future waves, and consequently more infections that would affect low and middle income countries, and that would slow the time to reach critical vaccination level as well as herd immunity. This, as such, would lead to widening the economic gaps between high-income countries as well as low-income countries, whereby high-income countries would be able to recover faster than low-income countries. Vaccine inequity means that healthcare systems must continue to focus on managing COVID-19. And this is going to place a strain on these healthcare systems. This would lead to limiting the capacity of healthcare systems to manage other needs. This will expose healthcare workers to infection and would reduce an important vital human resource. The strained healthcare systems would be less likely to monitor any other emerging threat. In fact, the COVID-19 pandemic has led to major immunization setbacks between 2019 and 2021, with more than 68 million children not catching up on their vaccination, and approximately 4 million of these are in the Middle Eastern region. This has led to a sharp drop in routine vaccination coverage and consequently a fall in the number of children being up to date in getting vaccinated against vaccine-preventable diseases such as diphtheria, tetanus, and pertussis. And in fact, we are observing currently in many countries of the Middle East outbreaks of measles. Reversing the drop in vaccination will be a major challenge requiring substantial investment. High vaccine coverage is extremely vital for economic recovery. And in fact, this was demonstrated with higher vaccination rates that supported labor market recovery in high-income countries, whereas in low-income countries, low vaccine accessibility slowed growth. They were associated with more lockdowns and consequently created further disruptions. And this ongoing gaps in vaccination may further widen and increase the economic gap between high and low income countries. Countries with a high rate of vaccination like we've mentioned previously, are likely to recover faster from the economic shock of the pandemic, and vaccine inequity accordingly will undermine the economic recovery of low and middle income countries. A wide distribution of low and high income countries across the Middle East exists, with 13% being low income of these countries, 19% being lower to middle, and 19% being upper to middle income countries compared to 50% high income countries. Consequently, because of this wide distribution and variation, vaccine inequity will have a greater impact on the economic recovery of these lower income countries. Another important healthcare challenge is the development of COVID-19 variants. In the presence of vaccine inequity, COVID-19 variants would emerge and would lead to important healthcare challenges. These variants can have many mutations that could be associated with immune evasion, specifically escaping the protection of available COVID-19 vaccination. An example of this is the Omicron variant of concern, which is the latest variant of concern. More than 50 mutations are present in this variant of concern that were associated with escaping or immune evasion from most of the neutralizing antibodies that are generated as a result of COVID-19 vaccination. And so we always have to keep in mind the risk of associated with the lack of vaccination and with vaccine inequity. These include the risk of infection, the risk of leading to more severe disease and consequently to hospitalization, and thus impacting healthcare system and placing additional strain on the healthcare system, more difficult to treat or diagnose disease, the loss of efficacy of available vaccine, and at times increased transmissibility. Within Omicron, and like we have mentioned previously, numerous variants have emerged. Some of these are reported or defined as variants of interest, and others are defined as variants under monitoring. At this stage, and based on the recommendation of the WHO Technical Advisory Group of Virus Evolution, we are not calling these emerging sublineages or variants of the Omicron variant of concern as variant of concern, but rather either, like I've mentioned, variants of interest, VOI, or variants under monitoring, VUM. The variants of interest include known or predicted types of variants to have a growth advantage over other variants or previously existing ones. They could also have epidemiological sign of an emerging risk to public health. And we have many of these variants of interest circulating in many countries of the Middle East. Similarly, we have a large number of variants under monitoring that are also circulating in several countries of the Middle East. A variant under monitoring is a variant that has or acquired a genetic change that may affect virus characteristics and may have a growth advantage, but phenotypic or epidemiological impact is still unclear and requires investigation. With the emergence of new sublineages of the Omicron variant, the available current vaccines may not provide sustained protection from infection or transmission of these sublineages. Vaccination should aim to provide long-term protection against severe disease, hospitalization, and death from current and future variants. The primary series or the initial 2-dose vaccine series has limited efficacy against COVID-19 variants, in addition to the fact that we have waning immune responses following a specific period of time after vaccination. And so this is why we have to promote the uptake of booster shots. Booster doses can increase variant targeting antibodies. In addition, variant targeted boosters may offer the greatest protection. It is important to also highlight the fact that studies estimate that any booster shot can provide additional protection against newly emergent or emerging COVID-19 variants. And in order to confirm that booster shots can help protect against new variants, a large matched retrospective cohort study was conducted in Qatar. The aim of the study was to determine the effectiveness of booster versus two-dose primary series. The study was comparing boosting with Pfizer-BioNTech vaccine versus the Moderna vaccine, both messenger RNA-based vaccines. The primary outcome or endpoint was symptomatic infection, and the secondary endpoint was severity of disease leading to hospitalization or critical disease or death. And in fact, the boosting with Pfizer-BioNTech vaccine led to 49% reduction in risk of symptomatic infection, as well as 77% reduction in risk of severe disease and consequently hospitalization or death. Boosting with Moderna resulted also in 47% reduction in the risk of symptomatic infection. This confirms that booster doses offer protection against variants, even if not variant targeted. Finally, during this video, we have walked through the different components that are impacting equity issues in the Middle East. We also went over what are the most important and efficient communication strategies that we could use in order to improve the uptake of COVID-19 vaccines in the Middle East. And we also finally advanced the emergence of new sublineages of variants of concern that have and could have detrimental effect on public health policies as well as healthcare system if vaccine inequity is not improved in the Middle East. I thank you for joining us in the discussion addressing COVID-19 equity issues in the Middle East and Africa. This completes our series on COVID-19 vaccination in Africa and the Middle East. And for more education, please watch our other videos in this series. We hope it has been useful to you, and thank you.